Good morning. My name is Jermaine Tazano, nurse practitioner student from University of Texas at El Paso. I'll be doing the case presentation for the patient in 805 this morning. This patient is a 74-year-old female that was admitted last night. We got called during rounding to see the patient for who was complaining of shortness of breath. The patient is 74-year-old, past medical history, COPD, sleep apnea, hypertension, hyperlipidemia, anemia, and she's morbidly obese. She was admitted from the outpatient surgery center after she underwent a balloon endoscopy for a GI bleed and AVM of the small bowel. Apparently, post-procedure, the patient became severely hypoxic with oxygen saturation in the 80s and low 90s. She became confused, developed a fever, and had some chills and wriggles. She was then transferred to the inpatient side of the hospital with a diagnosis of possible anesthesia reaction. This evening, the nurse, upon assessing her patient, noticed that she was severely short of breath, she was tachypnic, and she was using her accessory muscles. So she then activated the rapid response system on this patient. So we came to the bedside to assess the patient. Upon her reviewing her chart, her review system, at this time, upon her assessment, patient is positive for shortness of breath, tachypnea, and use of accessory muscles and wheezing. Cardiovascular-wise, she's positive for palpitation, negative for chest pain. GI, she's negative for abdominal pain, negative for blood or black stools, negative for constipation, nausea, and vomiting. Endocrine, there's no pertinent positive, everything is negative, negative for cold intolerance and heat intolerance. Genitourinary, the patient is negative for dysuria, hematuria, urgency, or frequency. Musculoskeletal-wise, she's negative for, musculoskeletal-wise, she's positive for generalized body aches. Skin-wise, negative for rash, breakdown, or ulcers. Neuro, the patient is positive for lethargic and increased somnolence. Psych-wise, she's positive for anxiety, but negative for agitation or any behavioral problems. Her past medical history is as stated above: COPD, sleep apnea, hypertension, hyperlipidemia, anemia, and morbid obesity. She denies any past surgical history. Also, her family history is non-significant. She doesn't really remember. She doesn't really remember any past medical history for any family member. Social history: the patient is not married. She, however, has two small children. She has two children and she lives with her two grandchildren, she said. Not really sure, but she has two children that lives in the state in Houston with her, and she gets good support from her family. She used to be a smoker, but she had quit. She said about 10 years ago she hasn't smoked, and she doesn't drink except on occasions, which is like maybe a party, a birthday, or some family gathering, which she says is rare, not even monthly. But if there's one, she'll drink an alcoholic beverage. Physical exam: her blood pressure was 143/68. Her pulse was 95. Temperature is 100.8. Respiratory wise, she's breathing anywhere from 22 to 25 breaths per minute. Her saturations: upon her arrival, the patient was already put on non-rebreather mask by the nurses, so she's saturating right now at 100% on 15 liters on the non-rebreather. Pain score: she verbalized a pain score of 5, which is a generalized body aches. Constitutional, the patient is awake, alert, and oriented. She appears anxious and in acute distress. Neuro-wise, she's lethargic but easily arousable. Her speech is clear and her sensations are intact. HEENT, normocephalic, atraumatic, extraocular muscles are intact. Her pupil is equal and round and reactive to light and accommodation. Mucous membranes is moist. Her nerves are patent. No nasal discharge and no septal abnormalities noted. Her neck is supple, no JVD, and no trachea deviation present. Cardiovascular wise, she has a regular rate and rhythm, no JVD noted, no murmurs, no gallops, no roars. Pulmonary wise, patient has expiratory wheezing. She's tachypnic and she's using accessory muscles to breathe. I could say her respirations are very labored. Her abdominal wise, abdomen is distended, it's soft, it's non-tender. She has positive bowel sounds and no guarding. Normal range of motions in all extremities. She's able to move all her extremities. No edema noted, no clubbing, no cyanosis. Her skin is warm, dry, and intact. No rash, no ulceration, no breakdown. Her assessment for this patient, differential diagnosis can include, but not limited to, acute hypoxemic respiratory failure, hypercapnic respiratory failure, COPD exacerbation, anxiety disorder, and adverse reaction to medication, which is anesthesia that she recently just received. The plan of care for this patient, the priority differential diagnosis will be acute hypoxic respiratory failure. We did a stat ABG, pH of 7.2, PCO2 51, PO2 was 126. This ABG was done on 100% non-rebreather, and a BiCAP of 23. We did a stat chest X-ray, EKG showed normal sinus rhythm. There was no ST segment elevation or no changes, nothing to appreciate in her EKG. We also gave the patient a stat breathing treatment. We gave her Duonep, and then we ordered a scheduled breathing treatment of Atrovan, and then a PRN breathing treatment of Duonep. And based on her ABG, we've decided we'll put the patient on a BiPAP. We started her off at 10/5, but she was still really labored, so we've gone up to 15. We went up to 15/7, which the patient is currently at 15/7 this morning. And chest X-ray, came back, and it was normal. There was nothing of concern. And then a second differential diagnosis for this that we thought of for this patient could be, patient could have thrown a PE, I guess, just post-procedure. She's been under anesthesia. She's morbidly obese. She has a history of hyperlipidemia, but we ruled the chest X-ray didn't show anything. And after talking to the attending last night, he did not want to do any CTPE protocol. She just wanted us to monitor. He wanted us to monitor this patient on the BiPAP, and then if any changes, and plus her vital signs were not showing any sign of a PE. So we really with that differential diagnosis, that's why that differential diagnosis took a second place for us. We'll just monitor her. And then it could be her COPD exacerbation, which is the third differential diagnosis was COPD exacerbation. We put her on some breathing treatments, and then we'll just keep her on the BiPAP tonight. We will repeat an ABG. We repeated an ABG at 4 hours after we started her on the BiPAP. That was about 1:30 a.m. in the morning. There was really no significant change. Her pH was still 7.2. Her BiCAP PCO2 was 50, just 1 point. It had dropped from, it was 51 earlier on when we did it. So we decided we'll keep her again, we'll leave her on the BiPAP and repeat another ABG 4 hours after that, which is going to be about 5 a.m. In the morning. So they haven't, it's what, 6 o'clock now. BiPAP ABG was just sent to the lab about 30 minutes ago, so we're still waiting for the results. And we spoke with the attending at 1:30 a.m. when we repeated that BiPAP, and he said if the next BiPAP, when we repeated the ABG, if the next ABG has not shown any significant improvement, then the patient will be moved to the IMU unit. So that's why patient is still here at the moment. BiPAP is still at, her settings is still at 15/7 with 60% FiO2. And so if we'll pass it on to the day NP to just follow up on the ABG, and the plan of care is to move the patient to IMU if this second set of ABGs has not shown any significant improvement. Patient would have been on BiPAP for at least 8 to 10 hours. And that is the end of my report. Thank you.